should PAE be performed only, alongside a urologist, not in the same room? I mean, but basically, a patient who's already seeing urology. And I'll tell you to start off, when I started doing this, I felt very strongly that, I needed to have urology on board. I went out and spent some time with Ari when he was still at UNC maybe 5 years ago, and saw how they were doing it. And I came out there convinced, it's like, this is the way, they follow up with urology. And then I got into practice, and I just waited and continued to wait for, any referral from urology. I did a lot of work, trying to get these referrals, do a lot of good work outside of the prostate space with these guys, and nothing came. And what I started to see was a lot of self-referred patients, and some of them, were already seeing a urologist. Some were not interested. And Sam, for me, I've gotten to where, I haven't really had much of a choice, because some of these I just kind of have to deal with on my own. I've got a urologist that I can refer to for anything like that, but I'm kind of interested in getting your take on it. I'm sure you guys have a very robust relationship with urology there. It's a little bit easier for you, but I'm sure you find self-referred patients too.
Speaking openly, probably 75 to 95% of my practice is self-referrals.
Wow.
Honestly.
Okay.
It's, most patients, what I've found is, unlike fibroids and gynecology, most men have a transactional relationship with their urologist. This is something I learned from Bob Vogelsang, actually, in that, you only really go and see your urologist when you have a problem. You're not seeing them after, childbirth for your whole life. And so, a lot of men are not, wedded to continuing to see their urologist. So
great point.
Once they have the diagnosis of BPH, they're looking for all their options. And so totally reasonable to see them after that.
So when you get a patient who self-refers, do you have them see urology as well?
So typically, what I've found is, and I think it's probably different, everywhere, is a man will not show up in my clinic unless they've been told they have BPH and they've been diagnosed with it. Because otherwise they have no reason to see me. And so they're a very well-educated population in general. They know what the treatment options that are out there. They've been told about TURP or other minimally invasive surgical therapies. And they're like, it doesn't really sound like that's what I want to have a scope and, et cetera. I won't get too vulgar on the podcast. They already know what they're in for. And so they've already educated themselves, and that's why they've come and seen me. So I typically have patients who have already had the diagnosis of BPH. Okay. That being said, occasionally you see ones that, somehow find you anyways. And I do like them to see somebody to confirm in the EMR. Yeah, BPH, not neurogenic bladder, not something else.
Totally. And, it's been a challenge debating, for some of them that haven't, or that, travel from out of state, how much of the workup I need them to do. And I haven't decided, I haven't really come to a conclusion on this. Do I insist that they get Uroflow or not? I don't know. How important do you think Uroflow is in the workup?
So, when we started doing all this in the beginning, and this was, stuff that Ari and Sunny had pioneered early on in the stream courses and such, that was a big component of it. But I think now that we've gotten more comfortable and there's a lot more data about PAE, is it really necessary? A lot of urologists will manage these patients based on clinical symptoms alone, AUA symptom score, and all these validated questionnaires. Maybe they have a Uroflow in the office, maybe they don't, but they're not dependent. They're not completely dependent on that for their treatment. And so I don't think we should be either, as long as they have the true diagnosis of BPH. That should be sufficient.
That's a great point.